Hi everybody, welcome to Respiratory, which is your first bit of content for this fall. The piece that I'll be podcasting for Respiratory is an A&P review as well as a quick review of how to assess the respiratory system. Respiratory system is divided into your upper and lower respiratory systems. Within your upper respiratory system is your nose, sinuses, pharynx, larynx, and trachea. Within your lower system is your bronchi and your alveoli, your lungs, and your rib cage and intercostal muscle. Your nose is intended to filter and humidify the air that we breathe. Your larynx is your voice box. Your pharynx is also known as your throat, which connects your nasal and oral cavities. Your trachea is your windpipe, essentially. It cannot collapse. It is made of smooth muscle and C-shaped rings of cartilage. Your lungs, you have a right lung, which is made up of 3 lobes, upper, middle, and lower, and you have a left lung that is made up of just 2 lobes, upper and lower. The pleura is the lining of the lungs, and the pleural fluid is the fluid that allows the motion of the lungs. So, as we begin to dive into respiratory, I want you to think to yourself what truly is the job of the respiratory system. The job of the respiratory system here is to oxygenate all of your cells and to eliminate carbon dioxide. As we breathe in, remember that we are bringing air into our lungs and it comes in contact with the blood. The blood absorbs our oxygen and carries it to all parts of the body. At the same time, the blood is giving up waste matter, carbon dioxide. The carbon dioxide is carried out of the lungs when we breathe out. This cycle is known as a respiration. There are a couple of pictures here just for you to reference. In this picture you can see where the diaphragm is, along with the abdominal muscles and the chest wall muscles. This picture here is a good picture because it shows you the trachea and the bronchus and the bronchial tree and getting ready to branch into the alveoli. Each and every one of the structures of the respiratory is important because it can be specific to different disease processes. The lower respiratory tract you can see here starts at the bronchus. The bronchi branches into bronchioles. The bronchioles have mucosal glands that cover the lining of the airway. And I don't think this picture shows it very much, but you have terminal bronchioles, which are even off of that bronchial tree, and those terminal bronchioles play a role in gas exchange as they lead to the alveoli. Okay, I was trying to get back to the slide that was before this, but it would not let me. The slide before this was the picture of the alveoli enlarged so that you could see it. I just want to spend a minute and talk about the alveoli and how important they are. Each of us have approximately 300 million alveoli. They are the final branching of the respiratory tree, and they are the primary gas exchange units of the lung. The gas-blood barrier between the alveolar space and the pulmonary capillaries is extremely thin, and because of this, rapid gas exchange can occur. So, at all times, the O2 in the alveoli must be kept high, while the CO2 levels, the carbon dioxide levels in the alveoli, must be kept low. So this all happens as a result of a pressure gradient. So what do I mean by that? So your oxygen and your CO2 move from large concentrations to low concentrations, which is known as a process of diffusion. So your O2 moves from your alveoli to the blood and the capillaries, and your CO2 moves from the blood in the capillaries into your alveoli. Once the CO2 is in your alveoli, the CO2 is exhaled through expiration. This whole process is very important to understand, and understanding how important the alveoli are will help you to grasp all of the disease processes later on, especially when we start talking about COPD and emphysema. Okay, so chemoreceptors, now that we've talked about alveoli, let's move on to chemoreceptors. Chemoreceptors detect the levels of carbon dioxide in the blood. So what is the process that actually triggers our respirations? Well, it all begins in the respiratory center, which is in the medulla. There, nervous impulses are sent to your intercostal muscles in the diaphragm, and this happens via the intercostal nerve and the phrenic nerve. And this whole process increases your breathing rate and the volume of the lungs during inhalation. Chemoreceptors affect your breathing rate, and there are two different types of chemoreceptors. Central chemoreceptors are located in the medulla, and they detect changes in the pH of your cerebral spinal fluid. They do not respond to a drop in oxygen and eventually desensitize. Whereas your peripheral chemoreceptors, they're a little bit different. They are able to detect changes in blood oxygen and carbon dioxide, but not pH. These peripheral chemoreceptors do not desensitize, and their effect on breathing rate is less than that of central chemoreceptors. Okay, here's another picture just of the alveoli, just to kind of give you a visual of the oxygen in and the carbon dioxide out. Here is just another visual of your diaphragm and showing how it moves during inhalation and exhalation. And so you can see that your diaphragm during inhalation is pushed downward because your lungs are full, and you can see during exhalation that your diaphragm is pushed upward because your lungs are smaller. Okay, your parietal pleura lines your thoracic cavity, while your visceral pleura is the covering of the lung, and your pleural space. Your pleural space is potential space, where the pleural fluid is. The pleural space is just a small area between the two layers of the pleura, and is normally filled with a small amount of fluid, which I mentioned earlier is pleural fluid, and that allows for movement of the lungs. Okay, so normal respiration. All of these things have to happen in order for us to have a quote-unquote normal respiration. Most of the oxygen that gets into the blood from the respiratory system is transported by hemoglobin to the cells of the body. The relationship between the concentration or partial pressure of oxygen and hemoglobin saturation is an important relationship. Partial pressure is the individual pressure exerted by a particular gas within a mixture of gases. In other words, the air that we breathe is a mixture of gases: nitrogen, oxygen, and carbon dioxide. So, if you were to take a balloon and blow up a balloon, you would know that the air creates a pressure that causes the balloon to expand. The part of the total pressure generated by the oxygen is the partial pressure of oxygen. The part of the pressure generated by CO2 is the partial pressure of carbon dioxide. So this may sound confusing now, but it will all make sense when we talk about ABGs. Hemoglobin saturation is the extent to which the hemoglobin in the blood is combined with the O2 and depends on the partial pressure of oxygen of the blood. So, if you're looking at oxygen saturation and you're looking at a pulse ox, your normal is really greater than 94%. But if you're looking at the partial pressure of oxygen, which can only be measured via an arterial blood gas, the range for that is 80 to 100. Okay, so again, and you'll hear me say this over and over again, how does this exchange of O2 and CO2 occur? So by diffusion, which we talked about a couple of slides ago, O2 diffuses from the alveoli into the blood, and the CO2 from the blood to the alveoli so that we can exhale it. So the pressure or concentration of O2 in the alveoli has to be at a higher level than in the blood, and the pressure of CO2 in the alveoli must be lower than the level in the blood. We do this with every breath. Every time we breathe, this cycle is happening. We are bringing in fresh air that has lots of oxygen and not too much CO2 into the lungs and alveoli. Couple of side notes just to take into consideration with the elderly population. They naturally have changes in their alveoli as they get older. So aside from somebody with a disease process like COPD or emphysema, elderly people, as they age, their alveoli have a reduction in surface area, which limits their gas exchange. They also lose elasticity in their alveoli, which again inhibits gas exchange. So just something to keep in mind. Okay, so that was your mini A&P review, and really we'll kind of be talking about all those things as we go through some of the disease processes, but at least gets your brain thinking about the respiratory system. All right, let's talk a little bit about assessment. Again, all of this should be reviewed from things that you learned last year. These are just some key terms that I want you, you should know. Abdominal breathing is using your accessory muscles to breathe. Apnea, not breathing at all. Bradypnea, slow respirations. So, you remember that your normal respiratory rate is 12 to 20 for an adult. So bradypnea would be less than 12. Cheyne-Stokes respirations, that's when you have rapid, heavy breathing, absent breathing, rapid, heavy breathing, absent breathing, and that repeats over and over again. Cheyne-Stokes, commonly seen in patients near the at end of life. Dyspnea, shortness of breath. Eupnea just means normal breathing. Gasping, self-explanatory. Tachypnea, which is not listed on here. Tachypnea is an increased respiratory rate, so that would be greater than 20. Hypoxemia, important term. Decreased blood in the decreased blood oxygen level. Another very important term, orthopnea. If someone has orthopnea, they cannot breathe in an upright position. I'm sorry, if they have orthopnea, they can only breathe in an upright position. Remember when you are doing your respiratory assessment that you want to assess everything that affects the breathing, not just the lungs, nose, sinuses, your upper and lower respiratory system. What techniques are you going to use? Inspection, palpation, percussion, and auscultation. We will talk about all those here in just a second. Okay, so as you are getting ready to assess a patient, make sure that the patient knows who you are, what you're doing, you provide a privacy, all those good things. Patient position, are they comfortable? If the patient is in an uncomfortable position, chances are their respiratory rate is not going to be accurate. Position of the nurse, so Are you on the side of the bed? Are you at the end of the bed? And the sequence of exam, which we're going to talk about, again, inspect, palpate, percuss, auscultate. We'll talk about all those here in detail in just a second. Okay, I think it may have cut me off on the last slide, but in relationship to obtaining a good health history from your patient, including, their respiratory history, disease processes, any medications that they're on that could affect their respiratory drive, difficulty breathing, cough, chest pain, history of smoking, any environmental exposures, what the present problem is, family history, all of those things. When we talk about inspection, you want to make sure that you inspect the patient's skin, posture, symmetry, chest contour. We are looking specifically at the AP diameter of the chest. Patients who have COPD have a barrel chest, which we'll talk about more when we talk about COPD, but they have an enlarged AP diameter, which is where that comes into play. Looking at the slope of the ribs, color of the chest, configuration and shape of the scapula and chest wall to make sure that it's even and symmetrical. Here's a picture of a patient on the far left with kyphosis. On the right, that S-shaped spine, that patient has scoliosis. Again, more inspection, thoracic motion to make sure that it's symmetrical, respiratory patterns during normal breathing and also during deep respiration. I think I talked about this on a slide a couple slides ago. Inspiratory phase, diaphragm. As you're breathing in, your diaphragm moves downward. As you have the expiratory phase and you're exhaling, your diaphragm moves inward or upward. Okay, next on the list is palpation. Palpation uses the sense of touch to feel or press on the body. You want to use the most sensitive part of your hand, which is your palm. There's light palpation and deep palpation. The back of the hand is good to use for temperature. The palm of the hand is good to use to detect vibrations. You are also palpating the posterior and anterior thorax for tenderness, any masses or abnormalities, crepitus, fremitus. Fremitus is tactile vibration of the chest wall that results from speech. You're also palpating thoracic expansion. So back to the word fremitus. How do you check for fremitus? You have the patient repeat the word 99 as you place their hands, your hands around their chest wall, and you feel that vibration with your hands. I believe there's a slide next that gives you a visual of how to do that. If there were a solid mass in the lung, you would feel increased fremitus. If you had a disease process like emphysema, you would hear decreased fremitus because there is more air. Air does not conduct sound. Oh, I think I just talked on that slide. Okay. So here's the picture that I was talking about for palpation with fremitus. That's the positioning that you would use as you have the patient repeat 99. Okay, let's talk for just a second about percussion. Percussion, I'm sure as you remember from last year, is when you strike an area of the body in order to produce sound. With percussion, you are using a quick, sharp tapping of the fingers or hands to produce the sound. This allows you to locate the position and size of underlying structures. When it comes to the lung, it can actually allow you to determine if there is consolidation or mass or fluid in the lung. More air equals more vibration, which equals a louder, longer note. Less air equals less vibration and a shorter, softer, and dull note. So you can see in this picture the positioning of the hand and how you tap on the finger and how you percuss posteriorly. You always want to go apex to base, and a normal percussion sound is resonance. If you heard hyperresonance, that may indicate emphysema. Here's anterior placement. Percussion technique, I think we kind of talked about this in the last slide. Press the middle finger of the non-dominant hand firmly on the body part. Strike that finger with the top of the middle finger from the other hand and listen to the sound that is produced. Another visual there for you. Okay, so the normal percussion sounds that you can hear, resonance. With resonance, that is what you would hear over hollow organs like the lungs or an air-filled cavity. Hyperresonance, lungs in small children or maybe adults with emphysema. Tympany, air-filled body parts like the bowel or stomach. Dullness, high-density structures like the liver. That area like the liver lacks air to resonate. Flatness or flat, percussing over solid masses like bone or muscle. Okay, probably the part that you are most familiar with when it comes to respiratory assessment is auscultation. Hopefully you guys are well versed with how to use a stethoscope by now. And hopefully you're fairly well versed with your breath sounds, both normal and abnormal, which we'll talk about all of them here in just a second. Documenting lung sounds. When you document lung sounds, it's important to document exactly what you're hearing. There are a couple of slides here coming up that kind of give you an imaginary grid, if you will, in order to find landmarks along the respiratory system when it comes to assessing. So you can kind of see on this the intercostal spaces. I think just gives you a good idea of landmarks. Posterior thoracic cage. Again, you can see the intercostal spaces, important when you are assessing the respiratory system. Okay, so when we talk about normal breath sounds, I will go ahead and tell you that these are nice to know. You'll notice that throughout my teaching I do a lot of nice to knows and need to knows. These are nice to know terms. In practice, you do not chart bronchial versus bronchovesicular. These are all normal sounds that we're going to talk about. If someone has normal breath sounds, you're just charting within normal limits, but I think that it's important to at least know these terms and recognize them. Bronchial breath sounds are heard only over the trachea. They're very loud. Vesicular breath sounds are heard over most of the lung fields, very low and soft, typically longer on inspiration than expiration. Bronchiovesicular, heard over the main stems of the bronchi, medium pitch, inspiration heard equally. Vesicular breath sounds, I'm not sure if I skipped, I might have accidentally skipped that slide. Vesicular breath sounds also heard over most of the lung, low and soft, inspiration longer than expiration. Okay, so we're going to take some time here and talk about abnormal breath sounds. This, to me, is definitely a learned skill in nursing, and it takes a lot of practice. But we're going to talk about the abnormal sounds and what type of patient that you would hear those abnormal sounds on. This slide is a nice to know slide. Okay, let's see here. Hyperpnea, increase in depth of breathing. That would mean somebody maybe who's exercising. Hypoventilation, not breathing enough, not breathing deeply enough. Kussmaul's respiration is a very deep, labored breath pattern, typically associated with somebody in DK. Orthopnea, again, shortness of breath when flat. You cannot lay flat. You have to be elevated to breathe. Let's kind of go ahead and talk about the different types of crackles that exist. Okay, so to me, when you say crackles, there is a difference between fine crackles and coarse crackles. To me, coarse crackles are louder than fine crackles. Both types of crackles can be cleared when the patient coughs. When you have crackles, that indicates that there is some type of fluid in the lung, maybe pneumonia. Crackles, to me, I've always associated them as a popping sound. If you picture or can listen to pouring milk over your Rice Krispies in a bowl, or sitting outside listening to the fire and that popping sound. To me, those are coarse crackles. Fine crackles, to me, just a lesser version of the coarse crackles, not quite as loud. When you hear the term rhonchi is a very sonorous sound. It is very loud, lots of fluid in the lung typically, lots of inflammation in the lung. Secretions are typically in the airway when you hear this. To me, rhonchi sounds like a train is coming through your lungs. It's just very, very loud. Air is attempting to move through those narrow airway passages. Wheezes. If you have asthma or you know anybody with asthma, you know that wheezes can be heard on inspiration or expiration, and they are very musical. That's probably the easiest way to describe them. Stridor is very, very high-pitched. Stridor is a noise that you hear when someone's airway is closing up, and stridor is a sound that most of the time is audible just standing there. You don't need a stethoscope to hear it. Another term, a pleural friction rub. When your pleural lining is inflamed, you can hear a pleural friction rub. But when that lining is inflamed, the lung is, when that lining is inflamed, there's no fluid to provide that